Good morning for everyone, and thank you for the holder and to take me here to present for you for the topic for today from cerebral venous thrombosis. We have a case study for 17 patients in SAS hospital, but today I would like to present you for two very unique case, and one case for pediatrics and one case with the stenting. And we will begin the presentations with the background from the cerebral venous thrombosis. This is a very rare case because it's the very last study in Turkey. It seemed like into 6 years in 35 stroke center. It's just 5 patients with the CVT per year for each center. So that is very rare case. And the CVT is defined by the thrombosis of the intracranial veins and the dural sinuses and has an estimated annual incidence, very rare. And it's often occurs in the patient who are very young and like for the traditional risk factor for ischemic stroke, like another risk factor. And up to 1% of the on stroke globally are caused by CVT, as in systematic review over 8,000 patients. And with the mean age of CVT is around 32 years old, so very young. And only 10% other case occurs in the patient over 60 years old. And there is a female predominance. So let's say there is 2.5 2 over 3 of the cases occurring in the woman. So we know about the occlusions in the dural sinus vein. There's will be increase in the venous pressures and reduce for the capillary perfusion pressures, and which is resulting in the cerebral edema and hemorrhage after. So the headache is the primary symptom, sign, the symptom of the patients is maybe a symptom come from the compression of the nerve fibers. Um, and the CVT is often occur in the patient who are in the hypercoagulable stage in the COVID-19 pandemic. So you will see the patient with the COVID-19 infections. Usually we give the patient with the anticoagulant for the oral, yes, and the patient have the hypercoagulable stage. And in this pandemic setting, the number of the patient with the CVT increasing. So why we miss it in the practice? Because it's the rare disease I mentioned before in the beginning of the presentations. It's just five cases for the last stroke center in Turkey in 1 year, and the mimic is more common in diagnosis like suprarenal hemorrhage, and another diagnosis, as you can see on the present. And another sign and symptom is not specific, and we can see on the another disease. So we begin with the case reports for the first case. This case is the male patient for just 52 months old and live in the Mekong Delta. And 6 months ago, he got the COVID-19 infection without any concomitant disease and without any development abnormal. And just 4 days ago, before the onset, before the hospital admissions, he got the headache, and the headache increasingly over day by day. And the day before, he got a seizure and severe headache. By physical examination, we cannot see anything happened. It's just in the neurological is the anterior mental status with the Glasgow scale is 13 points, and the quadric paralysis with the muscle strength is 3 over 5. So we did the MRI. So on an MRI, you can see the bilateral thalamus edema with the no flow in the with the no flow in the gallbladder and the internal cerebral and the straight sinus thrombosis, a symphytic thrombosis. And you can see here, we can see on the SWI confusions. So we can see on the SWI, we can see the blood clot in the straight sinus thrombosis and the gallbladder right internal cerebral and the gallbladder vein. So he was underwent for the endovascular treatment for 30 minutes after the MRI had finished. And this is the characteristics of the DSA for general anesthesia. And the procedure time is just 1/10 minutes. And the use equipment, we're using the two access site. One for the femoral artery for right ICA using the 4 French vertebral angial catheter and the 8 French femoral veins guiding position in the right internal jugular vein. And we're using the large bore suction catheter for Sophia Plus 6F. We're using the stent driver for catch field V35. And also we can use the balloon for the dilations. So the first one at the beginning with the arterial venography show no flow in the inferior sagittal sinus and the straight sinus. So the MRI is accurate. With the MRI 3 Tesla, we can see very accurate the blood clot and the MRI without using of the contrast. After that, we super selective for using the microcatheter to the distal of the ISS. And then we do some direct suction with large bore catheter Sophia 6F with 2 attempts. And then the stent driver with using the stay safe technique 2 attempts. And then after we do for the 4 attempt with the stent driver and the adapt technique, we cannot see any change in the flow in the ISS. So the next one, we want to use we decide to use the dilation with the balloon. And with the 4 attempt of thrombectomy, angioplasty with the J balloon, and the size is 4 and 40. And then the finals is acceptable. We can see the flow. We can see the flow on the ISS, and also we can see the flow on the straight sinus. For the gallbladder, the right gallbladder, we don't take it as the first approach because very difficult to approach for the gallbladder. We try, but in the 30 minutes we cannot approach to the gallbladder and the internal cerebral brain. So we decide to stop at the moment, and then the patient transferred to the ICU hospital with the hospital cost in the ICU for 4 days and the inpatient department for 10 days. And the treatment we're using the anticoagulant for the enoxaparin. Let's say it is 0.1 milligram per kilogram for assay for BID for 7 days, and the Sorrento 50 milligram half of the tab POKD for day 5 of the enoxaparin. And in the ICU, the 48 hours of the post EVT, the patient is fully conscious and the RB comment very good, no hemiparesis anymore. So let's say in the very acute phase, the patient is fully recovered. And in the department days, 10 days, sign and symptom improve without any signs of the hemorrhage event anymore, no recurrent. And this is the MRI at the discharge of the patient. We cannot see any edema on the left side anymore, but we can see the edema on the right side of the thalamus, but the patient have no symptoms, sign no symptoms. So let's say this is asymptomatic. And yes, because the blood loss is still there, so we cannot see the flow very clearly on the MRI. So this MRI we do with no contrast by 3-test lump MRI. So this slides we presents again the sway of the patients after do with the EVT. So you cannot see the blood clot in the transverse and the straight sinus, and also for the IRS on it anymore. So let's say the EVT is very quite good. And after 3 months, the patient can he can stand up by himself. He's laugh a lot. He can run a lot. So let's say no sign and symptom, and MRS is 0. So the second patient is the 52 patients for female patient is living in Mekong Delta also. And the past medical history is the hypertension and oral contraceptive for 3 years. And the oral contraceptives is the risk factor for the CVT. And very specific for the oral contraceptive, not other routes of the contraceptive like ASIs or another. No risk factor, just oral. And the 7 days ago, she got the headache, and the sign and symptom is the same, increasingly day over day. And the same day with the ER, the right side weakness, unable to move, and severe headache for 2 hours from the onset. Uh, but by the physical examination, we found the patient partial conscious, and she can already comment with the let's go around 14 points. With the right hemiparesis, central facial paralysis, and the knee scar is around 7 points. So at this time, we do the MRI with the cerebral edema on the left occipital lobe. But you can see on the left side, is the MRV. We cannot see any flow on the FS, superior sagittal sinus, and also on the SWI. The SWI, you can see the blood clot and the hemorrhage on the occipital, and some clot on the SSS, triple S sinus. So at this time, we decide to take the patient for optimal medical therapy. Because the patient is still conscious and the orbited comment, still hemorrhage, but not so severe. It's just mild hemorrhage. And the optimal medical therapy with the anticoagulant for the enoxaparin, 1 vial for 0.6 milligram for BAD, and after 3 days, 3 days after, the patient subsidence for fell into coma with the let's go around 7 points with the right hemiplegias. And at this time, we do the MSCT. The MSCT, you can see the diffuse edema on the left hemisphere with the hemorrhage is not increasingly, just focus on the left occipital lobe. And she was also underwent for the EVT for 15 minutes after the non-contrast MSCT finishes. With a general anesthesia for the procedure time around 100 minutes. And the usage equipment is last year with the previous patients for 5 French femoral artery for left RCA, and the AA French femoral vein shields for guiding position in the left internal jugular vein. And for this patient, you can see the equipment we're using is a lot of. We're using the stent driver, we're using a large bore suction catheter, we're using the balloon, and we're using 2 balloons with the smaller one and the big one, and also we're using the stent. Yep. So the arterial venography show no flow in the triple S sinus. So you can see no flow. Yeah, from the distal one to the Yeah. And the first one we try with the direct suction by the adapt, and we use the support from the SEPS 8. The SEPS 8 is the equipment we're using for the eliminate the blood clot in the distal of the suction catheter. We're using for 3 attempts, and then 2 attempts with a strand driver by using the safe techniques. And there is no flow in the triple S. There is very mild flow on the proximal side, uh, but no flow, really flow on the distal side and on the occipital lobe. And then we decided using the balloon. And this is the balloon, the big one, the 60 and 6 and 60. And we dilate from the distal side to proximal, and then no flow, still have no flow. And at this time we think about the what should we do right now because still no flow. We're using the dilation, stent driver, direct suctions, no flow, and the patient condition very severe. So now we look at the current evidence for the stenting in the venous side. There is still have some study and have some case study from around the world around using the stenting in the venous side. And we can conclude that venous stenting would be a good option in rescue therapy in highly selected patient and in proper setting. And we think that this is the proper setting for using the stenting for the patients. And then we're using the stenting for carotid for 9 and 60. And on the left side is the positioning, and on the right side is the no on the native DSA. We call that the ballot stenting. And this is the positioning on the left side, and the stent is fully dilations on the right side. And then we can see very good angiography with the very good flow from the distal to the proximal of the triple S. And the post-EVT treatment, we're using the triple therapy, double therapy, the enoxaparin for the 7 day, the same with the previous patients, and the Radasat with the oral coagulant on the day 5 of the enoxaparin. And the next one, we're using the clavurel 75 one tap POQ day from the day 2 for the stenting. And the patient stay in the ICU for 7 days. After 3 days of the IV sedations and mechanical ventilation of the for the edema, she partial conscious, and the last goal is around 14 points with the right hemiplasia, no increasing in the muscle strength. And in department for 10 days, sign and symptom improve. In the discharge, she can fully conscious, good orbit command, but still have the heavy paralysis for 1/5. And this is the MRCT for the post EVTs. Still have the diffuse edema on the left side hemisphere, but no more hemorrhage anymore. Follow up for 6 months. On the left side is the you can see the artifact on the triple S for the stenting and the hemorrhage also, but no edema on the left side hemisphere anymore. And you can see on the right side, the flow of the triple S is still permanent. Yes. So let's say the EVT, we have a good decision after 6 months. So I want to conclude my presentation for the treatment of the CVT. The first line therapy for the CVT is optimal medical therapy till now. But in the proper setting and the proper circumstance, we can change to another approach. So like endovascular treatment. So you can see there is a 5 indication for the CVT treatment. Like clinical deteriorations despite anticoagulation, like the second case I present to you, and the coma, like the first case I present to you, and the contraindication to anticoagulations. and deep CVT for the first case. The first case we have two indications. First one is coma, and the second one is deep CVT and the ICX. So thank you for that. Thank you for your